Okay. Navigating Very Unusual PTCA Complication, an annual story of bailout by alternate openers. Respected audience and panelists, Assalamu alaikum and very good morning. I'm Dr. Ab al Manjur, working as an assistant professor in the peripheral region of Bangladesh, that is in Khulna City Medical College. Let's talk about the story. So this Mrs. X, 54 years old, diabetic hypertensive lady, presented to a EMR with complaints of an on and off central chest pain along with severe shortness of breath and profuse sweating for 2 days. Initially, she was diagnosed as a case of acute non-ST elevated MI with left ventricular failure and with old MI antroseptum and underwent for CAG in the following day. The CAG revealed severe single vessel coronary artery disease and recommended for PCI later as a indexed procedure. PTCA was done 6 days later in the same hospital setting. So this is the CAG of that patient. Left system showed 99 to 100% near total occlusion, medial dilation with TME2 flow and 40 to 50% lesion in mid sacs. Right system shows 40 to 50% osteoproximal lesion in high took of PLV branch of RCA. So we decided to go for PCI to LAD. So as we facing the direct wiring, so first we have to take the balloon for support to wiring the vessel. So which was done by 1.5 into 10 millimeter NC balloon support. Sequential pre-dilatation was done with 1.5 into 10 millimeter and 2 into 10 millimeter NC balloon. 2.5 into 28 millimeter days was deployed. So now come to the complication. For post-dilation, when did I proceed with a 2.5 into 15 millimeter NC balloon? Suddenly I noticed a torn part of a wire stuck to the distal end of the guide catheter. Immediately I took out the balloon and wire to ensure that it is not a torn part of my wire, and successfully I rewired the LID without any complication. So when I think about the complication, then my technician, he shared a very unusual story, which was happened just 2 days back, and definitely it was beyond anybody's case. So what is the story? The story actually is a story of negligence. 2 days before, during another procedure, distal part of the used whisper wire was torn and lost. After vigorous investigation, a torn wire was not found in any part of the body and guide catheter. Operator then asked them to discard the guide catheter, but cath lab staff didn't follow and put that catheter again in shelf after cleaning an ETO for reuse. Then 3 questions came to my mind. Despite cleaning, why this wire was not came out? Why fluoroscopy failed to reveal the wire if it was deeply impacted in guide catheter? And why did it came out during introduction of post-dilatation balloon, not with others? So that is my possible explanation. The possible explanation might be like this. The torn wire was deeply impacted in the proximal part of the guide catheter. Fluoroscopy was not covered the whole length of guide catheter on that day. And as my balloon was old and its rough surface might be dislodged from the inner wall of the following hard push at the proximal end of the guide catheter. This you can appreciate the diagrammatic representation. So there is a, actually the torn part was impacted in the proximal part. When I pushed the balloon, it is going to the distal part. So now come to the bailout. So we took a second wire and 2 millimeter new balloon to trap it, and then the whole system was returned together with torn wire. So you can see the procedure. The whole system was withdrawn. So after bailout, after withdrawal the whole system, the guide code again reduced and rewiring done successfully. This is the torn wire you can appreciate. So after post dilatation with 2.5 into 15 NC balloon, angiography showed good TME2 flow. So a take-home message: never push too hard when there is a resistance. Intervention is not a casual thing. Always stick with your senior's decision. Your simple negligence can endanger patient's life. Prompt recognition and decisive action are paramount in mitigating adverse outcome during PCI complication. Flexibility and adaptability in approach are essential when facing unforeseen challenges during intervention or procedure. Effective teamwork and collaboration among cath lab staff are crucial in managing unexpected complication. Thank you. Thank you for patience hearing.